dietary relationship. Encourage men to follow a low fat diet, one that is avoids red meat. Lifestyle is important. This includes a healthy exercise routine. Now, we haven't been able to demonstrate in clinical trials that exercise has demonstrated lower risk of prostate cancer, but weight loss and dietary modification in several studies has reduced the risk of having prostate cancer reoccurrence. So those men that were diagnosed with prostate cancer were treated who followed a controlled diet and exercise routinely were at a lower risk of recurrence of prostate cancer. And of course, smoking, that's also associated with many other cancers, such as lung and bladder cancer, may have a link to a higher risk of developing prostate cancer. Other things that we have noted in more of epidemiological studies, perhaps lower levels of vitamin D may be related to prostate cancer as well as chronic prostatitis. Um, the direct relationship still remains somewhat elusive, but wanted to just kind of put that out there. That's constantly research going on and trying to help figure out what other environmental or dietary or lifestyle risk factors exist. Now, most prostate cancers follow a pathology of what's called adenocarcinoma. For anyone who's on this talk or is viewing this talk, who has been diagnosed with prostate cancers, most men will be diagnosed with a subtype of cancer called adenocarcinoma. There are other types of prostate cancer that are extremely rare. In general, less than 5% of the time they get lumped into other variants, and they really depend on what origin of cell that these are arising from in the prostate. But in general, you may hear of terms like squamous cell or neuroendocrine. These tend to be more aggressive, that have a much higher risk of eventual life expectancy reduction and also metastatic disease. Now, clinical findings of prostate cancer can also remain elusive. In fact, most men who have early stage prostate cancer are asymptomatic. As I mentioned early in the discussion, most men that have urinary changes are related to benign prostatic growth. Typically, symptoms related to prostate cancer are associated with cancer that's locally advanced, meaning it's starting to push outside of the prostate, or has spread outside of the prostate, whether that be into the lymph nodes or to the bone. As prostate cancer becomes locally advanced, it can push into the bladder, causing changes in urination that can include obstructive changes like weakness of stream, difficulties initiating the stream, or eventually not being able to urinate. A backup of urine in the bladder can also lead to a backup of urine in the kidneys, can cause kidney dysfunction, a shutdown of the kidneys, and renal failure, which may require dialysis. When prostate cancer spreads to the bones, it can affect the health of the bones, causing them to become weak and brittle, and can also cause significant amount of pain. And so in the old days, going back over 5 decades, when PSA level was not readily available, many men presented to the emergency room with these symptoms, with not being able to urinate, perhaps blood in the urine, or sometimes in significant bone pain that only up until that point were they ever presented with and led to a diagnosis of prostate cancer. So fortunately, many things have changed with the last 50 years in studying prostate cancer. One of the things that can a become an emergency is when cancer spreads into the vertebral column and into the vertebral bones and can eventually push into the spinal cord, causing a compression of the spinal cord. And a compression of the spinal cord can lead to fairly quick paralysis, and also the inability to walk and sometimes loss of bowel or bladder function. And this can happen fairly quickly. And if not diagnosed in an expedited fashion, can lead to irreversible damage of the spinal cord and can lead to permanent paralysis. So this is something that fortunately is not commonly seen in the emergency room, but was not uncommon decades ago. Now, what are the signs when you go to the doctor, and what the doctor may be doing is, first of all, the most important thing still includes a rectal exam. I know that there has been controversy over whether a digital rectal exam is needed. Well, I think the role and the importance of a DRE is important for various reasons. One, a quick, relatively risk-free, a low kind of investment is a physical exam to better understand the shape, the size, and understand if there's any sort of nodularity. Not every prostate cancer secretes PSA, specifically those that are highly aggressive, like neuroendocrine differentiated or squamous differentiated prostate cancer. They may not secrete PSA and often are picked up on prostate exam, or if not picked up early enough, as I mentioned, can present with metastatic disease at the first presentation. What the urologist or the medical doctor is feeling for is a gland that's felt through a rectal exam to feel the backside of the prostate. We're feeling the prostate and ensuring that it has a smooth characteristic. It doesn't have any lumps or bumps or induration. So I still am a big believer in a digital rectal exam, especially if you get one once a year, and that's really what's recommended. Your doctor can then keep a track of any sort of changes as one ages. Um, in addition to a digital rectal exam, a PSA level, which is a blood test that stands for prostate-specific antigen, is a quick blood test to help to screen for prostate cancer. And that also recommendation is to be checked along with a rectal exam once a year. Now, as I mentioned earlier, some of the symptoms of metastatic disease can include when cancer spreads to the lymph nodes, and that can lead to swelling in the legs. And when it spreads to the bones, is bone pain, and then hopefully not involving the spinal cord, as that can present with uh, paralysis. There are certain blood tests that can lead to suspecting prostate cancer. When prostate cancer becomes locally advanced, it can obstruct the drainage of the bladder, can lead to renal damage, which is the medical term called azotemia. It can also lead to less red blood cell production or anemia, and that's typically seen when cancer is spread into the bones, as most as most red blood cell production occurs in the bone marrow in the bones. This can be replaced by cancer. Alkaline phosphatase is a non-specific blood test. We see that in several metabolic issues such as liver disease, but this number can also be elevated when cancer spreads to the bones, along with acid phosphatase. Now, PSA level has gone through various controversial discussions over the course of its invention years ago, and primarily because PSA is not specific to prostate cancer, meaning if one's PSA level is elevated, that does not mean that you automatically have prostate cancer. And the reason is there are uh, uh, many other things that can cause the PSA to rise. So traditionally in the United States, the way we measure PSA is a blood test, and typically our kind of cutoff for most men is 4 nanograms per milliliter. So typically, if your PSA level is consisting less than 4, the likelihood of having clinically significant prostate cancer is low. Of course, as the PSA level rises, so does the risk of being diagnosed with prostate cancer rises as well. And so typically men whose PSA levels are between 4 and 10 have about, in general, a 30% risk of developing or having prostate cancer, and a PSA level from 10 to 15 rises upwards of 50 to 60%. As you see here in this diagram, a high PSA level can be a sign of prostate cancer, but There's various other reasons for that, and these include a urinary tract infection. I've had patients who were admitted at the hospital who couldn't urinate or perhaps had a urinary tract infection, and their PSA levels checked at that time. That is not the time or place to check a PSA is in the hospital or in light of a urinary tract infection, because more likely than not, it's going to be abnormal and elevated. Certain exercises, specifically bike riding, can cause irritation to the prostate due to the seated position and can also cause a false elevation of PSA. And then prostate stimulation, such as recent sexual activity, ejaculation, or anal sexual activity, can cause a false rise of PSA. So we typically encourage men to abstain from ejaculation for about 48 hours before a PSA test. And less likely, there are certain medications that are associated with falsely elevated PSA level. So, how do we go about diagnosing prostate cancer? Well, firstly, we discussed the screening process with a rectal exam and a blood test. And having sequential rectal exam and PSA level is important because that trend helps clinicians and urologists to better understand the health of the PSA. Now, what do I mean by that? Well, as I mentioned, there still will be about 15 to 20% of men who will be diagnosed with prostate cancer whose PSA level is less than 4. So that if your PSA level has been hovering around, let's say 1.5 for the last 3 to 4 years, and then all of a sudden jumps up to 3.5, although it may fall under a safe number because it's less than 4, but that rise of 2 may be meaningful. And so if we didn't have prior PSA levels for comparison, we would never understand or would never even pick up the fact that the PSA level jumped 2 points within a year. So having a track record of PSA level is important. Now, in any men who have had an abnormal PSA velocity or an abnormal jump, have an absolute abnormal PSA number consistently above 4 nanograms per milliliter, or an abnormal rectal exam, and of course, a combination of these issues to be abnormal, should be counseled on undergoing a biopsy of the prostate. The biopsies are typically done through two approaches. One's called a transrectal ultrasound, which is an ultrasound probe that's inserted into rectum and a small biopsy needle that's sampled through the rectum to obtain samples of the prostate. Now, typically, we get anywhere from 10 to 12 samples during a biopsy session. The other approach is what's called the transperineal approach, where again, an ultrasound probe is inserted into the rectum, and instead of the needle going through the rectum, it goes through the perineum. Now, that sometimes can be a little bit more technically challenging and often may require a sedation to be done under sedation. And of course, skill level of the urologist and comfort level is important. Most commonly, these procedures are about 3 to 5 minutes, and expectedly, there's always a small risk of bleeding and infection, which most patients will undergo an antibiotic prophylaxis. Now, if a biopsy is positive, there's a grading system that we all follow, and this is a universal grading system that helps all sorts of treating physicians to universally grade a disease, whether it be the urologist, the radiation oncologist, or the medical oncologist. And this grading system was developed roughly 40 years ago. This was called the Gleason system. And the Gleason system was based on how well differentiated a prostate cell is. And so a prostate cell that is uniform has one has the ability to kind of trace or circle around the gland. It tends to be less aggressive. And as you can see in this diagram, the more disarrayed the cells are, almost like shaking up a snow globe. And as you see here, there's just, a whole slew of different cells shaken up, tends to be more aggressive. And it becomes difficult to identify an individual gland. As you see here, you see clumps of this. There are no glands that one can see, and you end up having sheets of cells, which tends to have the highest grade. So the Gleason score is a grading system that's a number plus a certain number. So most men who get diagnosis of prostate cancer will have a score, for example, a 3 plus 3. which means that their most common pattern is a Gleason grade 3, followed by second most common pattern of a Gleason grade 3. It is not uncommon to have a variant of this where the most common pattern may be a 3, and there is a smaller mixture of 4, so that obviously the diagnosis would be a 3 plus 4 equals 7. And then vice versa, if the most common pattern is a 4, and followed by the second most common pattern of 3, it can add up to a 7 as well. But prognostically, a 4 plus 3 cancer tends to be more aggressive than a 3 plus 4. And so here's kind of the grading system. Um, what has evolved over the last 5 years is something called a Gleason grade group, and this is seen on the right column here. Typically, the Gleason grade, which is in the middle, has been replaced, but we still grade cancers in both fashions to help kind of uniform and make sure everyone understands the appropriate grading. Grade group 1 is a Gleason score of 6 or less. A grade group 2 of a Gleason score 3 plus 4. A grade group 3 of a Gleason 4 plus 3. And then a 4 that may have a slew of numbers adding up to an 8, whether that's 4 plus 4, a 3 plus 5, or a 5 plus 3. And then finally, the highest grade one can get is a grade group 5, which consists of either a Gleason 9 or 10 disease. Okay, now once the biopsy is done, depending on the degree of the aggressiveness, most men who have low-grade disease, which would be a grade 1 type of cancer, may not need any further imaging or any sort of diagnostic purposes, whereas men who tend to have higher grade disease may require further imaging, and that's listed here. MRIs have become quite good in their technology. Men who were diagnosed with prostate cancer who needed an MRI 10 years ago required an MRI which involved inserting a coil into the rectum, which has now been replaced with upgrading of the machine. There's something called a magnetic coil called a 3 Tesla or a 3T, where if anyone is pursuing an MRI of the prostate, really should question whether their clinician has ordered a 3T MRI. This really is the best way to fully image the prostate. MRIs in general are typically reserved for men who have had a negative biopsy, so somebody who's had a PSA elevation or an abdominal rectal exam, which led to a biopsy which was negative, and their PSA level continues to rise, may be a candidate to getting an MRI. And or somebody who has been diagnosed with an intermediate to high risk disease may need for staging purposes to make sure that the cancer hasn't spread outside the prostate. There are certain individuals whose insurance companies may allow an MRI to be done before a biopsy. But this again is restricted based on insurance policies, and universally getting an MRI as a screening process has not been standardized, and it's something that's not routinely done. And so even though many things have come along the way, PSA level still remains kind of the universally accepted way to screen for prostate cancer. Um, there are other imaging studies your urologist may order after the diagnosis of prostate cancer. This can include a CAT scan, which again helps us to identify metastasis or spread of cancer specifically to the lymph nodes, and it's typically an imaging that helps to visualize the soft tissue in the abdomen pelvis to make sure cancer hasn't spread not only to the lymph nodes, but other organs like the liver. In addition, MRIs are useful for certain men who may be undergoing treatment, like a removal of the prostate or radiation therapy, to better plan and guide, to better understand if there's locally advanced disease. Bone scans are usually reserved for men who we suspect have high-grade disease that may have spread outside the prostate. So that typically includes men whose Gleason score is an 8, 9, or 10, or a Gleason grade of group grade of 4 or 5, uh, or their PSA level is greater than 20 at the time of diagnosis. What a bone scan helps to visualize is to make sure that the cancer hasn't spread into the bones. What many of us are obtaining now is perhaps a better a body scan, and that's a PET CT scan, which helps to image from the head down to the mid thigh. And these special PET scans are using an agent which is called the PSMA, or prostate specific membrane antigen. And what is happening or what the agent helps us to identify is by it tags prostate cancer cells. So if there's cancer that's outside of the prostate, we can pick up this spread uh, uh, at a much sooner level than the traditional bone scan. And so this is kind of like the latest and greatest, so to speak, is a PET scan that's with the agent of PSMA tagging agent. So many of you may come across that term through your journey of prostate cancer. These are what CAT scans look like. On the left is a CAT scan. This is a patient that has lymph node disease that has spread, and we see these bulky lymph nodes. And then the ultrasound, which is often used at the time of a biopsy. Many men will ask me, doctor, did you see anything at the time of biopsy? As you can see, the imaging of a prostate on ultrasound is not so great, but an ultrasound is typically used to kind of navigate the areas where we need to biopsy. But this obviously is kind of an exception where we see this mass that's pushed outside the prostate. So normally that prostate would follow an outline in this fashion, and then this mass has pushed outside. So that's very rare to see, and most often a mass like that would be felt on an exam. Now, how do we treat prostate cancer? A lot of this depends on whether this is localized disease or disease that spread outside the prostate. If the diagnosis leads to a localized disease, then there's several options, of which one can include active surveillance. Um, the optimal way to treat prostate cancer is individualized, and yet we still don't, it's very controversial to recommend one treatment option over the other. So typically, men in my practice who are diagnosed with earlier stages of prostate cancer are often offered active surveillance. Active surveillance is something that we have learned over the course of the last 20 years is a great treatment option for men who have early grade cancer. And the reason is, for most prostate cancer, as I mentioned earlier, is a slow growing process. And so for many men, um, uh, the likelihood of them dying from the disease is low, and rather most men will rather die with the disease rather than from the disease. But it's our job as urologists to help risk stratify which men qualify for active surveillance. And so, besides a a low Gleason score, there are certain things that I use in my practice that help to better understand the genomic expression of these certain genes, as I mentioned earlier, that are related to high risk disease. So there are testing available that the tissue sample that's obtained at the time of biopsy can be sent for further analyses that gives us a report in understanding at a RNA or a DNA level or a molecular level whether this cancer is behaving like a low risk disease, or even though it appears, the architecture appears favorable with a low Gleason score, that genetically it's programmed to a more aggressive disease. So that allows us either reassurance that the cancer is low risk, or may help uh, um, lower our threshold to treating prostate cancer rather than watching and waiting for it. Now, active surveillance is typically an algorithm that we monitor PSA levels more closely, and that can range from every 4 to 6 months. And it also involves future biopsies and things like MRIs. So what's happening in this situation is that we're not kind of burning a bridge. We're not pulling the trigger as far as removing the prostate or radiating it, but we recognize that one has prostate cancer. We also recognize the fact that it's a low-grade disease. So we watch it until it may subsequently become more aggressive or change. Now, in clinical trials that have enrolled tens of thousands of men, what is the overall likelihood of one falling out of active surveillance? Meaning, you have 100 men who are offered active surveillance. Over the course of the next 5 years, how many men will continue active surveillance is roughly 80%. About 20% of men will fall out of active surveillance and will eventually need some sort of a definitive treatment. And so, you know, I think that's great because if we can avoid any sort of definitive treatment that has its side effects, I think offers men a preservation of quality of life, as well as being able to enjoy the longevity of life. In clinical trials that looked at active surveillance, there really was no significant increased risk of disease mortality at their follow-up of 10 and now robust follow-up of 15 years, so that their counterparts who were offered active surveillance that eventually fell out of active surveillance that needed definitive treatment were not at any higher risk of mortality than their men who were offered early treatment. So there's definitely good, robust data on this. Now, there are several treatment options, and again, with a clear conscience, I can't tell you one's better than the other. As a surgeon, of course, I'm trained to remove a prostate, and uh, uh, obviously there's always some bias when you talk to a surgeon in treating prostate cancer. And I say that to all my patients. If you talk to a surgeon, he may or she may lean towards removing the prostate. You talk to a radiation doctor, and he or she may recommend radiation therapy. But what the clinical trials demonstrate is that there's no significant benefit over one technique over the other. So why would one choose one over the other? Really depends on the expectations of the patient, as well as what the quality of life issues that are related as potential risks of each intervention. So what a radical prostatectomy is, it's involving a surgical procedure where we go into the operating room and remove the prostate. Along with the prostate, we're able to remove the seminal vesicle, which is an organ that is intimate with the prostate and has a risk of about 10 to 15% of the time having prostate cancer locally spread into the organ, and also are able to remove some of the lymph nodes in the pelvis. Men who are looking for a definitive treatment that offers them a PSA level that's 0 or undetectable, this would be the only way to pursue that. Men who are looking to better understand the disease or understand it completely in that sense where a biopsy only gives you a glimpse or a snapshot of what the cancer is doing through small tissue samples, removing the prostate gives you the whole picture. One can better understand the disease, more accurately diagnose the Gleason score, and better understand if microscopically disease has left the prostate gland. So there's definitely benefits of removing the prostate. What also some clinical trials will demonstrate to benefit from a prostate removal, the life expectancy of a patient should be at least 12 to 15 years, because again, prostate cancer for most men is slow growing, that if it reoccurs, men who have had their prostate removed tend to do slightly better in long term, uh, in the long term, and that may be related to the fact that it's easy to pick up a recurrence with a PSA test, and that any little rise of PSA as little as 0.1, 0.2 can indicate recurrence of disease, so that can be treated at an earlier fashion. Now, given that prostatectomy offers certain benefits, there are certain risks to removing the prostate, which can include urinary leakage or incontinence. Fortunately, with the robotic approach, not only has it helped with earlier physical recovery, but we've seen a better control of urinary incontinence and a quicker recovery of urinary control after prostate is removed via the robotic approach. And the other thing that will change almost immediately is the health of the erections. And that is because the blood and nerve supply that offers healthy erections is lays close to the prostate, and that these get disturbed and can take upwards of 12 to 18 months to recover. So those are the two kind of quality life changes that are at risk. And so some men who do not want to have that healing process that is needed with surgery may opt for radiation therapy. Radiation therapy has also seen significant amount of improvement in the last couple of decades. This has included better delivery of the radiation, a more specific approach in avoiding toxicity or damage to the surrounding tissue. And the surrounding tissue, as we earlier discussed, includes the bladder and the rectum. And so there are certain changes one will experience despite the technology improving. Men who have radiation therapy will experience changes in urination that's usually characterized as frequency, urgency, waking up at night. It creates an irritation to the bladder. Also, it can affect the rectum and stools. So some men will experience loose stools, diarrhea, and sometimes blood in the stools as well. Now, fortunately, as I mentioned, uh, urinary incontinence improves with time after surgery, so does the irritative symptoms. And in both situations can take 6 to 12 months to kind of return back to normal urinary habits. Erectile dysfunction can also be at risk after radiation therapy, although it's a slower process. Initially, erections may be preserved, but if we follow men 2 to 3 years after surgery or radiation therapy, the risk of erectile dysfunction is relatively the same. What has changed, as I mentioned, the technology, and many of you may hear about technology such as CyberKnife or globally what's called a stereotactic radiotherapy, that's SBRT, which has allowed us to deliver higher doses of radiation at a shorter frequency. So what traditionally would be an 8-week course or roughly 35 sessions of radiation can get condensed to 5 to 7 treatments. Brachytherapy is seed implants. Seed implants have fallen out of favor. Brachytherapy data on intermediate or high risk is not so good. Brachytherapy data is best on low risk disease, but what we've also learned is most low risk disease doesn't need treatment. And so most men who get diagnosed with low risk disease are often encouraged active surveillance rather than seed implantation. Also, brachytherapy is a skill set which has also been um, kind of fallen out of favor. So many of the radiation oncologists that are finishing their training will never learn how to apply seeds to the prostate. So finding a radiation oncologist that does brachytherapy will continue to be far and few. Cryosurgery is also another way for some men who are not looking for removal of the prostate or to undergo radiation therapy. Cryotherapy is a way we freeze the prostate. It's done in the operating room. It's done in one shot. Usually reserved for men who are older, who are looking for treatment but not having to go the physical recovery of prostate removal or the frequent trips to get the prostate radiated. The data on cryosurgery also has been now extended up to 10 years plus and shows fairly good control of prostate cancer as well. And then focal therapy is still, in general, not accepted universally. There are certain centers that are doing focal therapy. Um, Right now, most definitive treatment like radiation or surgery is geared towards the whole gland. All of the gland gets treated. Focal therapy involves using a freezing method or laser therapy to focally treat a nodule in the prostate. And so for men who have an MRI that demonstrates a nodule and also biopsy proven, may be candidates for focal threat therapy. And again, for many who are looking for focal therapy, should seek centers that are enrolling in clinical trials. Um, Recurrent disease, so after the treatment of prostate cancer, whether it's radiation or surgery or cryotherapy, some men will have their PSA level reoccur. Of course, the goal with surgery is to have an undetectable PSA. With radiation is to have a PSA level that's less than 2 nanograms per milliliter. So a rising PSA level after treatment can indicate that the cancer has come back. Many men will question me and say, Doc, I had my prostate removed 10 years ago. The surgeon said everything was removed, margins were negative. Why am I seeing a PSA level that's detectable now? Well, the truth of the matter is, despite all the improvement in imaging, at the time of prostate removal, uh, one cannot pick up a few cells that have already escaped the prostate gland, and may take time for a few cells to then eventually become detectable. So most likely reason for PSA recurrence after prostate removal or radiation is that it probably was um, spread outside the prostate at the time of treatment. And so both are at risk, both men who have prostatectomy or radiation, and often is based on how aggressive the disease is. For men who have low risk disease, the likelihood of PSA coming back after prostate is removed is somewhere in the realm of about 5% at 5 years and 10% at 10 years. And so 90% of men who are low risk disease who have had their prostate treated will enjoy an undetectable PSA 10 years out. And that risk increases with the risk of the prostate cancer. So for men who have intermediate risk, that risk of PSA recurrence at 10 years may increase to 10 to 15%, and at high risk, upwards of 25 to 30%. What happens if the PSA level comes back? Well, your urologist may further do staging studies. For men who have had radiation therapy, may require repeat biopsy. But as I mentioned, PET-CT scans have helped bridge this gap, and since they're so good, we can often pick up metastatic disease or cancer that's spread outside the prostate. Once prostate cancer spread outside of the prostate, it's no longer a candidate for definitive treatment. So the role of removing the prostate or radiation therapy is typically out of question. Um, Once cancer spreads, the best we can do is to slow down the cancer activity, and that often is manipulated with manipulation of hormones. The fuel for prostate cancer is testosterone, and so what we can do is use certain medications to help lower the androgens or the testosterone hormone to help slow down the reproduction of the cancer cells. An analogy I like to use with my patients is that if you imagine a pot of boiling water, that boil of water is the cancer cells just bubbling and growing, and what's feeding into the boiling water, or what's causing the water to boil, is a high flame underneath the pot. And so what we can do is we can lower the flames. We can never extinguish the flames. We can lower it to allow that boil, that high boil, to lower down into a simmer. And that's kind of what testosterone manipulation does. This was one of the few Nobel prizes that were given out to urologists. Dr. Hudges and Hodgkins were urologists in the 60s that discovered this pathway, that were able to demonstrate that prostate is influenced by testosterone, and removing the testosterone can help treat prostate cancer. So there's several medications that we can use. A big clump of them is called luteinizing hormone blockers, or LHRH agonist. Luteinizing hormone is secreted in the pituitary gland, and these medications help to lower the testosterone production through the manipulation of LH. There's also medications that help block the secretion of LH, and those are classified as gonadotropin releasing hormone blockers. And some of these names of these medications can include Lupron or Eligard. Zoladex is another one. There's now an oral medication that's an anti-gonadotropin releasing hormone called Orgovyx. And so there's several options, very effective in lowering testosterone levels and reducing the reproduction of the cancer cells, helping to bring the PSA level down. Now, of course, these medications will have their own side effects. Testosterone is an important functional hormone in the man, crucial for daily physical activity, energy levels, important in libido, muscle mass. So removing testosterone or lowering testosterone can lead to all those side effects. And the best way to kind of understand that is putting a guy through menopause, where hot flashes, fatigue, over a course of time, loss of muscle mass, gaining weight, um, can all uh, uh, be certain be side effects of these medications. There are also medications that get clumped into what's called anti-androgen. So unlike what I just described, medicines that lower testosterone, these medications help to block the testosterone from joining the receptors of prostate cancer cells. And testosterone, that's how it works. It binds to the prostate cell, sending a signal on the DNA to reproduce. And so these medications help block the receptors by stopping the testosterone from binding to these receptors, and in essence allows the cancer cells not to grow. And there's this whole slew of them. What I'm sharing with you is something called biclutamide and enzalutamide. And sometimes patients may be on a combination of these where they may require the testosterone production inhibition as well as an androgen blocker. Zytiga is a medication that works a little bit differently. Um, Most of the manipulation of the testosterone that's delivered through those LHRH analogs or gonadotropin releasing antagonist is through the manipulation of testosterone production from the testicle. There's still 10 to 15% of testosterone that's secreted from the adrenal gland. And so abiraterone is an agent that helps to block that testosterone production. So it further lowers the testosterone production to a negligible level. And also, what has been remarkable in understanding the biology of cancer cells over the last decade has been this expression of this gene called CYP17. And this is something that's highly expressed in cancer cells, and it's linked to the synthesis of testosterone. And so, uh, what tends to happen with men who uh, um, have low levels of testosterone through these medications, the cancer starts to outsmart and starts to make its own testosterone production through the expression of CYP17. And so, prostate cancer cells don't necessarily need a high level of testosterone. And so, the one way we've been able to demonstrate the importance of recognizing CYP17 expression is through this medication that helps block it. So Zytiga is often reserved for men whose um, prostate cancer is resistant to Lupron and other hormone treatment. And so typically the diagnosis is based on PSA rise, despite having a testosterone level that's low. And so this is an agent that's used for that. We're starting to use this earlier in the algorithm of treating even castrate-sensitive prostate cancer. Perhaps men who present with metastatic disease at a high volume may be offered now triple therapy where they may have Lupron, enzalutamide as a receptor blocker, and or a Zytiga to further suppress testosterone production. For men whose PSA level continues to rise despite these drugs that I mentioned, may have to resort to chemotherapy. Chemotherapy is a process or an infusion, an agent that helps to kill highly reproductive cancer cells. And the two agents that are approved are docetaxel and cabazitaxel. Of course, the invasiveness or the side effect profile tends to be higher with chemotherapy. But in general, of all chemotherapy drugs that are out there that treat all sorts of cancers, these tend to be better tolerated than most of the other chemo drugs. But this is something that would involve then a consultation with a medical oncologist. And as a urologist, I often will use a team approach. I often will send patients to radiation oncologists, as well as working closely with medical oncologists, and so that we all work as a team to deliver the best care, and not only the best care, the best outcome. And also, once prostate cancer spreads into the bones, and also is in a castrate-resistant environment. FDA approved several years ago medicine called Xofigo. This is a radiation kind of a radioactive based treatment. This is radium-223, which is infused in men whose specifically cancer spread into the bones and are having symptoms from the spread, which, as I mentioned, can be bone pain. This is an injection that's given once a month over several months to then bind into the minerals of the bone to deliver radiation directly to the bone tumors, and it helps to then limit the damage to surrounding normal tissues. So this is another approach in helping men who have advanced prostate cancer. And then to kind of finish the talk, to talk about immunotherapy, or many of my patients refer to as vaccine therapy. Sipuleucel T, or Provenge, is an agent that was approved by the FDA roughly 12 to 13 years ago, which is a very unique way in priming our own body to fight these cancer cells. The way that this is done is a patient who has prostate cancer, a sample of their blood is taken, their PSA is kind of isolated and customized. A vaccine is then made. This vaccine is then delivered back to the patient. And as with how all vaccines work, they create an immune response. So your body recognizes this vaccine or this prostate cancer as a foreign body and builds its kind of the immune response in having to fight cancer. Typically, this is reserved for men who have castrate-resistant prostate cancer, but there are clinical trials that are looking at using this mode of therapy in earlier prostate cancer, perhaps castrate-sensitive prostate cancer. But although it's called a vaccine because it's an infusion with an agent that primes the immune body, it's not a vaccine where it helps to prevent prostate cancer, but rather in helping to treat it. And so, went through a lot. I mean, I could spend probably a whole month on breaking down and looking at all the slides that we talked about, but I wanted to take the opportunity to kind of review kind of a general idea from signs and symptoms to diagnosis to treatment options. Of course, any patient that's undergoing the diagnosis of prostate cancer is always encouraged to kind of personalize their care with their urologist. I'm more than happy to share my expertise if anybody wants to seek a consultation. And I'll pull up that information from my office again real quick. That again is, let me just bring it up here. That again, my office address is at 955 Little Britain Road in New Windsor, New York, and the office number is 845-437-5000. Well, thanks again for joining us this evening. Hopefully, a lot of you learned about prostate cancer and are better informed of this. And I look forward to seeing you on the other lectures we have planned for this month. We have one coming up on low testosterone next week, and the week after on benign prostatic hypertrophy, or BPH. Thanks again, and have a good rest of the evening.